Donna, I'm going to pull this down. You can get started whenever you're ready.
Okay, I'll get started. Good morning. I'm Donna Christensen, and it's my pleasure to serve as your moderator for today's event. I'm a family physician who had the distinction of being the first female physician ever to serve as a member of Congress. I'm also a board member of Consumers for Quality Care, and we are so glad to be joining the New Jersey Healthcare Quality Institute to host this event. CQC's mission is to ensure patients and their right to high-quality healthcare remain at the front of the healthcare debate. We seek to provide a voice for consumers to tell their stories and demonstrate to policymakers the imperative that is quality and affordable care. Today's important event with the Quality Institute is to refocus on the importance of preventive care to reduce the risk for diseases, disabilities, and death. An estimated 41% of adults in the US avoided medical care during the pandemic because of concerns about COVID-19. We need to reverse that because there are millions of people in the United States who do not get the recommended preventive health care services. And so the Quality Institute and CQC have brought together industry experts today to share best practices and tools for you to use with your patients to return to pre-pandemic levels of preventive care. A couple of housekeeping items before we begin today's presentation. All phone lines will be muted for the duration of the program to limit background noise. You may ask questions at the conclusion of our panel presentation by typing into the chat box, or if you'd like us to unmute your line, please raise your hand by clicking raise hand in the webinar controls. Please know that this webinar is being recorded and a copy will be posted to the Quality Institute's website, www.njhcqi.org, later today. Now I'd like to ask each of our speakers to introduce themselves. Dr. Mary Campagnola, Dr. Peter Fisher, and Director Valerie Haar. Dr. Campagnola.
Morning. Hi, everybody. I'm Dr. Mary Campagnolo. I'm a family physician, and I'm a medical director for the value-based programs and payer contracts for Virtua Medical Group. And my clinical site is at Virtua Primary Care of Mansfield in Bordentown, Mansfield, New Jersey. I have a certificate of added qualifications in geriatrics, but I do see patients of all ages, though focused on geriatrics. Happy to be here. I'm also a member of the board for the Quality Institute.
Great. Dr. Fisher?
Yeah, hi, thank you. Thank you, Dr. Christensen, Tyler, Quality Institute, for inviting me today. I'm Peter Fisher. I've been a pathologist for at least a couple of decades. I'm the medical director for Quest Diagnostics in the East region, which is one of 6 Quest regions across the US. Our East region provides diagnostic lab testing services to about 40 million people in 7 states, and it ranges from New Jersey, New York, and PA, Pennsylvania, down to Maryland and Virginia. We manage about 30 labs across the East region, including rapid response labs, hospital labs, and our primary regional core lab, which is located in Clifton, New Jersey. Our Clifton core lab, just to give you a sense of scale, receives, processes, and results several 100,000 diagnostic tests each day. Much of this capability in being able to handle these test volumes is due to state-of-the-art large-scale automation. And the samples we receive come in from the entire spectrum of people seeking lab results, ranging from solo practice healthcare providers to multi-hospital systems, and from employee health programs to individuals requesting tests on themselves. As medical director, I have oversight of all the tests we perform, including, most importantly, the quality and the delivery of accurate results as rapidly as possible back to providers and patients. And today's topic on preventive care and testing is especially important to me, as I see the work we do at Quest as being critical to providing the actionable information needed by physicians and patients to improve health and to improve outcomes. In addition, of course, to reducing healthcare expense. And of course, it's especially important, as Dr. Christensen said, to have this discussion in the context of changes we've all seen in health screening patterns during these last now nearly 3 years of the COVID pandemic. So I look forward to the conversation. Thank you.
Director Har.
Yes, good morning. I'm Valerie Har. I'm a Senior Director at Horizon Blue Cross Blue Shield of New Jersey. So I straddle two roles there in community health, where I oversee our Neighbors in Health program, which I'm happy to say we just recently won an NCQA award for an innovation for that community health worker program. And also I work very closely with our pledge to diversity, equity, inclusion on a number of initiatives, working closely with the Healthcare Quality Institute around maternal child health in particular. And then I recently joined our network strategy team. So I do a lot to coordinate the various network teams at Horizon and make sure we're responding to network reporting requirements by our regulators and really looking to make sure we have a high quality network of providers and serve the best way to serve our members. Prior to joining Horizon in 2017, I was a Deputy Commissioner in the Department of Human Services and a former Medicaid Director for the state of New Jersey. Thanks.
Thanks. Dr. Campagnolo, would you like to just say a few more words maybe about Virtual Medical Group? I know you introduced yourself.
Oh, sure. We're a medical group in multiple counties in southern New Jersey, and we have 25 primary care sites. And so as far as our value-based work, we work with both the Primary Care First program that has Medicare patients involved, and also we work with multiple commercial payers on value-based programs as well as Medicaid in New Jersey. So we have much interaction with Horizon and Aetna, United, AmeriHealth, multiple payers in our area. And
Great.
I've been a part of the group since 2008 when we formed it. I was previously in private practice in Burlington County, and basically I'm still practicing in the same community.
Great. So we're going to begin with some individual questions to our panelists. And we do begin with you, Dr. Campagnolo. As a geriatrician, what strategies have worked in your practice to encourage older adult patients to maintain regular preventive care? And why is immunization adherence important? And what can clinicians do to keep their patients up to date?
Okay, so there's a lot in that question.
Yes.
Just coincidentally, I just wanted to open with last Friday's edition of the Wall Street Journal, and the main section had 2 articles on the same page that I thought were apropos to this discussion. One was showing that the American Cancer Society announced this year that cancer death rate has decreased by 1/3 in the past 30 years, and pretty much attributed to the fact that we have multiple various testings to do to help detect cancer early and then treat it. And then the other article was about vaccines for kindergartners that unfortunately fell at least 4 to 5% worse in areas where children were under the federal poverty level, as well as in rural areas. And that was for children who were born since 2018. So again, affected by the pandemic. So I thought those were 2 interesting articles that people might look at just to show the importance of screening and vaccines, preventive care. As far as the question about seniors, so we have multiple strategies within our group that have developed over many years. The first thing we've always done is to have some quality metrics, which generally coincide with the kind of standard metrics that the government and commercial payers have helped us to set. And we've always set targets for our group in order to aim for every year. In fact, right before this, I was on a meeting where we were talking about the current targets for this year. We did have to reduce those somewhat in the pandemic because, as we said earlier, people avoided some care. So measuring is important, I think, in any program for preventive care to encourage. If you don't measure, you don't improve, I think is really true. But what we've done for seniors, we do emphasize the Medicare annual wellness visit, which is a free Medicare service. And it has been shown that the seniors who do partake of that visit do have lower costs of care and better outcomes. So we've tried to impress that on our clinicians and staff as well as on our patients. And, it's always continuing to improve situation, but we have developed an outreach program where we encourage the patients around their birthday. They receive a card to encourage them to sign up. And we have staff that help to enroll them at the practice to do the visit. We also have worked with our clinicians and staff at the practices to schedule those visits when a patient is checking out from a routine visit. And so when they come in for the visit, they do have a team of people in the practice. They can work with the medical assistants, actually carry the lion's share of doing the requirements for Medicare on those visits. And then we also have population health RNs who can actually do the whole visit for us. That's part of the service with Medicare and has approved that. And then in that visit, we can go over the various gaps that patients might have in their preventive needs. The other strategies we have are related to our electronic health record, which has a health maintenance module. And we try to update that based on the current guidelines. And so we do encourage that those are used by our medical assistants in chart preparation for visits and by the clinicians at as many visits as they can. Personally, I try to do it myself at just about every visit, except for something really urgent or acute. Try to go over with the patient what their needs are as far as meeting those health maintenance requirements. And then the last part is also using what we call My Chart in our record, but it's considered a patient portal in electronic health records, which gives the patient an access to the health maintenance module, and so they can see what they're missing. And, often we do have patients who come in and say, oh, it looks like I need a pneumonia shot, or I need a shingles vaccine. And so it's a way to help them be aware of what's missing. And if they have received it elsewhere and we don't have it, they help us to update the information. So those would be a few strategies. The other things we've done are to have point of care testing available in the practices. And so those would be for things such as hemoglobin A1C for diabetics. We're able to do finger sticks. We're able to do urine for protein, urine microalbumin test in the practice, and also the stool testing for colorectal cancer screening. That one would be a stool fit test, which is something should be repeated every year. And also we've developed standing orders so the medical assistants can do all those tests. If they see it's lacking on the health maintenance, they can do that test and then report it to the clinician. And then we've also developed campaigns around certain metrics. So when we identify that we need to increase our breast cancer screening every year, colorectal cancer screening, and then diabetic measures, which often are bundled by the payers in our measurements. So they look at, say, the diabetic eye, urine testing, and hemoglobin A1C control. So we try to outreach to certain groups of patients throughout the year and to get them to come and do the needed testing. So they can either do it in the office, or some tests we might send to a lab such as Dr. Fisher's. We also have developed partnerships with certain groups that do the stool DNA tests that patients can receive in their home by mail and then send back by mail. And we've developed an interface that will come into our electronic record with those results. So multiple strategies. As far as immunizations, again, we use the modules that will show us which immunizations a patient is missing, and again, update, say for the COVID vaccines. Some patients got them in various locations that didn't interface with our record. So it's an opportunity to get the correct information from the patient's vaccine card or give them a vaccine in the practice right then when we see that they're missing it. And again, the medical assistants have standing orders for flu shots, for pneumonia shots, and the COVID shots right now that they can go ahead and administer them as long as there's a clinician in the practice that day. And so those would be multiple ways. I hope we'll get some questions generated from the audience on that.
How did COVID vaccinations do in your practice?
I guess one thing I would say is that it took a while within our state for the primary care practices to get vaccine access, but once that did happen, it's gone smoothly. We do see, again, anecdotally, maybe not quite as much uptake on the bivalent vaccine for various reasons. Unfortunately, some of the misinformation and public disputes about vaccines, and so constantly trying to combat that in our practice and encourage patients to get it. Again, overall, we do have a process, and we've been getting continued supply of the vaccine to administer it.
Great. Thanks. Thank you for that very comprehensive response. Dr. Fisher, the next question goes to you. Testing is obviously an important part of preventive care. So are you seeing testing rates return now to pre-pandemic levels? And if not, what are some of the barriers to testing access and the strategies that might be used to overcome those barriers?
Thanks. Yeah. So since my work is focused on lab diagnostics, most of what I can say is with that lab-based frame of reference, but it's, I think, still generally applicable to other non-lab tests, such as imaging, endoscopy, and so on. As I'm sure many people are aware, just to give some background here and context, screening test rates took a huge dip through the first 2 years of the pandemic. HbA1c screening for diabetes was down 65%. Prostate cancer, PSA screening, and tests for STDs were down 70 to 80%, and colonoscopies down by as much as 90%. So it's estimated that more than 25 million screening tests that would have normally taken place over that period just didn't happen. And as a result, of course, disease diagnosis has been delayed and resulting already in presentation that we're seeing with more advanced disease states, including diabetic disease and its associated complications, and people presenting with later stage cancers where screening can be, of course, extremely effective in identifying early cancers or precancerous states, such as with colon and breast cancer. So as patients have resumed more normal patterns, in this past year, lab testing has pretty much rebounded to where we're seeing normal or only slightly reduced testing volumes nationally. And Tyler, if you have that slide, if you can show that slide I'd sent. Yeah, what I want to show you is fairly recent data on what we're seeing in, okay, everyone can see that? Yeah.
Yes.
So what's very disturbing is that we're still seeing a significant reduction, more than an 11% decrease in the rate of new prostate and breast cancer diagnoses compared to pre-pandemic. And even in other, and you can see, and there are several cancers that were looked at, we've looked at, but even in other cancer types like colorectal, lung, gastric, cervical cancer, the numbers of new cancers being diagnosed is still not sufficient to offset the number of new cancer diagnoses that would have been delayed because of missed screening opportunities earlier in the pandemic. So there's a big loss of access to earlier access to care, not just preventive care, but to actually treatment and prevention of later stage disease. So the question is, how do we, thanks Tyler. So the question is, how do we persuade people, especially apparently healthy individuals, to seek appropriate preventive screening? And of course, Dr. Campagnolo has given us a great, insight into what she and, her practice is doing. But as with everything in real life, getting a preventive test on yourself takes planning, effort, and expense. And this is the way I see the world. from scheduling appointments to requesting time off work and undergoing a procedure that you'd rather not have, quite frankly, whether it's for a blood test or a colonoscopy, a cervical swab or a prostate exam. It takes a lot of conscious effort. And then after that, having to pay for it can represent a real challenge. Even today, as a comparison, 30% of prescriptions for medications go unfilled, mostly due to the cost of filling those prescriptions. That being said, I think there are several ways that we can improve screening rates. And I see three major levers to achieve this. One is improving education and communication. And second is improving access options. And the third lever is improving affordability and creating incentives. So let me just briefly talk about each three of those. Firstly, with education, messaging, and communication, we have to educate each other through every possible channel, using media, our employers, sending reminders from trusted providers, mailings from health insurance companies. And this messaging has to be engaging and it has to be repeated. You have to be persistent. The example, this past year, I was 4 months late with my own routine annual physical, and I received a one-line email saying, it's been, I think it was a text actually, it's been 12 months since your last exam, please schedule an appointment with your doctor. And that was it. I had no follow-up to this single reminder. We all need to remember that screening saves lives, so it's well worth as much of the extra effort that's needed on our part to do. Second lever is access and options. We have to make access easy. We need to offer rapid, easy access to schedule appointments, or even not having to make appointments at all, just walk in, something that Quest currently offers at our PSC's patient service centers with tremendous success. And we need to offer alternatives that make it even easier than that. For example, tests being provided by the employer at your work location and at health fairs. And offering, as you, Dr. Campagnola, said, offering tests to do the tests at home, either providing blood collections in the home or with self-collection kits. For example, Quest Health, our direct-to-consumer offering, offers tests that people can order for themselves, ranging from general health panels to cardiovascular disease and diabetes. And this is an option we found extremely effective, for example, with sexually transmitted diseases and HIV testing, giving everyone the option of using the privacy of their own home. We also need to consider offering testing options to people who are reluctant to have a specific test. For example, if the prospect of undergoing a colonoscopy is keeping someone from getting screened, even though this is the optimal screening method for colorectal disease, we should then offer alternatives, such as you said, home fecal occult blood, DNA testing, or genetic testing on a blood sample, which, while they may be less sensitive tests, they're certainly better than no screening at all. And the third lever is affordability and incentive. We're all very cost sensitive and healthcare isn't cheap. So figuring out how to offer preventive screening that's not only simple and accessible, but also affordable is really key. And this means we have to find ways of eliminating cost as a barrier to people seeking screening. I'll let Valerie comment on this, but from my perspective, besides the personal value of catching a disease before it's advanced or untreatable, just the simple economics of keeping people healthy is the advantage of employers and health plan insurers. So having employers provide health screenings for their employees and for health plans to offer incentives to their members for getting screened, I think would seem to be to everyone's advantage. So in summary, we need to educate and effectively communicate, and we need to make screening simple, accessible, and affordable.
Thank you. And I know this is not something that you're directly involved in, but Quest has been partnering with Black churches, which have trained and hired community health workers to help to get that messaging out and to make the connections, and also coordinating the testing with referrals to community health centers, the collaboration between different kinds of clinicians, whether it's a private doctor or a community health center, has been really helpful. So Quest has been doing quite a bit. I can speak to that because I'm on one of their advisory committees.
Thank you. Yeah.
So our next question goes to Director Har. Horizon Blue Cross Blue Shield of New Jersey provides full coverage of most preventive care services to its members with no out-of-pocket costs. So how do you inform your members of this benefit and how do you incentivize them to seek out preventive care?
Yeah, thank you. And I think Dr. Fisher said it all. And in terms of my notes and our sort of multi-pronged strategy, I think it's totally consistent with what Dr. Fisher shared. And I will, right, my disclaimer here is I am not a clinician, I'm not a physician, but I really want to talk about some of what we do. And I've heard repeatedly it's about partnership. And I think, this partnership, this collaboration, and the role Horizon can have as a convener has really helped in this area. So we do have some member, and these are new and emerging areas. I don't have all the specific details, but we do have member incentives and member rewards for, I think, across all lines of business for members to seek their preventive care. One of the, so we are definitely communicating directly with members, providing incentives, nominal financial incentives for members to get those screenings. And unbeknownst to me, and so maybe the audience doesn't know, is we have Horizon has a YouTube channel. And if you look on Horizon YouTube channel, we have lots of quick, catchy videos that people can watch. And also we definitely try to send those communications out consistent with, we all have every month there's sort of a recognition, whether it's, breast cancer awareness and screening, and so send and have those communications. We also have, we're of that generation now with social media. So in addition to the YouTube, right, using our social media channels, as well as our member portals for both Medicaid and our commercial lines of business to encourage health, wellness, preventive care, and also provide 24/7 nurse chats and telehealth. So I think a lot of that is us, again, trying to remove barriers, which I think Dr. Fisher, you spoke to. So just to pivot a little bit, the work that I do with community health workers, we have 11 participating provider organizations and community-based organizations like the Camden Coalition and the Trenton Health Team, who are recruiting non-clinical community health workers from their respective communities who are engaging some of our most vulnerable members. And that is really, we're trying to assess a member for some of their social gaps, but the community health worker can educate and empower members around preventive, the importance of preventive screenings, and remove barriers like transportation, food insecurity, other things that are impacting how they are connecting to the healthcare system. So the role of our partners and community health workers and the community is extremely important. And again, sort of just driving home, getting that message out in a multitude of ways. But in many cases, a community health worker is somebody that can build that trusted relationship and sort of have that breakthrough in communication. I'd say the biggest thing is, and hopefully Dr. Campanago, will confirm this, is we do a lot in working with our providers and especially our value-based providers. And there are, we know that the providers, as she mentioned, are outreaching our members. We are trying to provide data to our provider partners on our members, their patients, where there is a gap, and they can close those care gaps, and really encourage them. And that also then helps the provider improve their quality scores, which can lead to financial benefits for the provider. So a lot of this is trying to empower and enable our providers in order to outreach our members. So it's collaboration, repeat communication in a multitude of ways. And I think a good example, Dr. Christensen, where you were talking about Quest, is a good example of this partnership. Is we had a really strong partnership develop during COVID with some of the pharmaceutical manufacturer and pharmacies, chain pharmacies, faith-based organizations, and our Department of Health, where we were able to go into communities, meet the members where they were, and provide COVID testing and COVID vaccination. So we had pop-up clinics that we were conducting, and again, it was just different groups coming together and making that happen, and then continue also to support the Department of Health in trying to get particularly those pediatric immunization rates up. And so a lot of what we do is getting out in the community, and hopefully you've all seen some of our Horizon vans and tables and so forth at different community events. So I'll take a pause there.
Okay. And a lot of what you've talked about are things that we've done here. We got our providers and clinics involved in vaccinations and testing very early. We were very lucky about that, and had pop-up testing. We still, with the new sort of rise in cases, again, we're doing more pop-up testing and vaccinations as well. So this has been very, very informative. There are a few more questions, and audience, I'd like you to start getting ready to ask your questions. One of the things that may drive healthcare costs in terms of preventive care is unnecessary testing. So this is a question that anyone can answer. So it could be problematic. And what tools have you used to combat unnecessary testing, or would you suggest to our audience? Mary,
So
would you
I
like to
could start. Yeah, sure. I think the clinical folks in the audience would know, but maybe members of the public are not as familiar with the concepts of tests that have, any test has a false positive, meaning, that somebody's positive, but that really wasn't the condition that they have. And also there's false negatives where there might be a condition, but the test did not show it. So any test you do is going to have those potential responses. And unfortunately, for false positives, then that often leads to additional testing. And any tests, again, that start to become more invasive, do have risks associated with them, as well as the benefits of achieving, early detection of a condition. When we talk about imaging tests, we often have what's called incidental findings, which often are things that are found that may not be clinically significant, but do warrant more testing to assure ourselves that those are not clinically significant. And so, any test you do can have some side effect for a patient. And so that's where I think it is important that we educate ourselves and our patients on what are the right tests to do at the right time, and then some of the risks and benefits of those tests. So, that's kind of an ongoing challenge, I think, for all of us. I'm sure some of the other panelists have opinions on that too. And any test we do also has costs, and if we do tests unnecessarily, then the money that we're spending on that could have been spent on other beneficial things for patients. So we've tried to, within our group, have tried to look at, there's a program that was called Choosing Wisely that came from the Association of Internal Medicine Groups, and many of our other physician organizations contributed from each of their perspectives, such as I'm a Family Physicians, the Academy of Family Physicians contributed certain areas that they felt were important for their members to consider. One example might be MRI testing, in that MRIs should only be done for patients who have had back pain with red flags, meaning more than 6 weeks of a condition or some other red flags, things that would alert a clinician that there was something significant going on. And so, again, just trying to look at that and educate our own clinicians about that. We did a series of videos on the various measures that we thought were important to consider, and those videos still exist. They've been around. We did them about 4 years ago, I believe, and those have still been available and actually required for our clinicians in our various virtual medical group practices to view every year as part of their competencies. So again, some simple things we tried to do to alert ourselves of what we should and should not order. And also, I think it's a constant tenet in family medicine to, kind of educate your patients. If they ask for a test, you may not want to order every test somebody might ask for just because they want it, that you want to give the patient the education and be good stewards of our resources.
Yes, I'm glad you mentioned choosing wisely, because it's really been a tool that's helped clinicians and patients choose care that's really supported more by evidence and not duplicative of other tests or procedures that have already been done. Peter, did you want to add anything?
I'll just add, you've said a lot of it, right? And from the very practical point of view, from the practitioner point of view, I'm a lab guy, so data is, where I live. And just to give a sense of the scale of the problem, we all talk about it, but, of course, in lab, we are committed to only doing appropriate testing. And also, there's also the economic piece that we don't get paid for unnecessary testing. So
Right.
It's work that we have to do. We don't get paid for it. So just to give a sense of the scale of the problem. So Harvard Medical School study, probably 10 years ago now, found that about 30% of all lab tests were unnecessary. Probably, they say, but unnecessary. More recent study, 3 or 4 years ago, found that up to 70% of all lab tests done in a hospital setting were either clinically unimportant or unnecessary repeat testing, didn't bring value to the clinical situation. So, and the issue, as you said, Dr. Campagnolo, isn't just the cost of the test itself, but all the downstream consequences of doing that test, including, the cascading of follow-up tests. Well, this is abnormal, let me follow up, what else could it be? Unnecessary procedures and treatment as well. And even the preventive screening tests that we're focused on today can be unnecessary, like screening for prostate cancer in men over a certain age, right? So knowing the drivers of unnecessary testing helps create appropriate tools. And correct me if I'm wrong here, but again, the data or the studies show that physicians have said that the 3 biggest drivers, and they've given multiple options of listing, what is it that leads you to do a test when you don't really need it. The 3 biggest drivers were practicing defensive medicine because of malpractice concerns. Another one was just wanting to be sure or safe in the diagnosis. Yeah, I know what it is, but let me just be sure. And the third one is keeping the patient happy. Like patients come in with demands and they say, well, why don't you do this for me or this? So I think some of the most effective solutions that we've been involved with and have seen engaged in our hospital labs, for example, in reducing testing, unnecessary testing, has been to provide physicians with on-the-spot advice, right? Eliminates the time barrier, has to be easy, give them easy access through the EMR to evidence-based recommendations. So that mitigates the malpractice concerns, give them access immediately to diagnostic algorithms and order sets. So they're not ordering unnecessary tests in their battery of what should I be doing in this situation. And a constant plea we hear from physicians is they need more time, not only to review testing recommendations, but dealing with demanding patients and discuss better alternatives with them. I can't help with that, other than to say, if we can give them tools that, prevent them from unnecessary testing or give them the information there right away at the point of writing the script, I think that's very helpful. So EMR, oh, that's me. Sorry, I don't know how. Hold on. There we go. Sorry. So clinical decision support tools are invaluable, right? Both in the hospital and the outpatient setting, with pop-up warnings or hard stops and things like that. So no doubt in the near future, we'll also be seeing leveraging of artificial intelligence or assisted intelligence to help physicians' decision-making in real time as well. So those are just some of the thoughts that I've seen, but there are tools, how we engage them, how we engage with them, but there are real concerns from physicians as well that lead to unnecessary testing in many instances.
Thank you, but those types of things like choosing wisely and clinical decision support that the CDS has put together are really helpful to help avoid physicians feeling that they must do a test defensively, and should help to cut down on unnecessary testing, which again increases costs. Valerie, did you want to answer that question? I have one more question that I'm going to ask before we go to the audience.
Sure, I'll be brief, and this is, the providers know this, and I'm sure it's not without controversy, but Horizon's intent is to rehab edits. It's why we look for medical necessity, pre and post authorization. That's the spirit, that's the intent of those. So totally agree and support what everyone is saying, and we do have vendors that we use to help educate providers and explain if we are denying coverage of a service, why. So those are standard tools that I'm sure the audience is familiar with from an insurer. Yeah.
Yes. So my last question to the panel before we go to the audience is about telehealth and its importance in preventive care. Mary, I'll start with you, but give everyone an opportunity to answer.
Sure, thanks, Donna. Telehealth, as people have said over the last few years, has been one of the silver linings to the whole COVID pandemic, in that it quickly became a standard way to provide care. And fortunately, the insurers have, both governmental and commercial, have continued to cover the telehealth. And we'll continue to advocate for this to become a standard way of practice. I think there's many ways telehealth has been used, and kind of commonly now, I think, I would say there's a few different areas. We still tend to use it for acute problems with upper respiratory infections. We've still tried to kind of modulate how many patients with actual upper respiratory symptoms come into a practice, and keep them safely segregated from other patients who are not feeling those symptoms. And so when we're doing a telemedicine visit under that kind of circumstance, it's still an opportunity to review the health maintenance with the patient, and if they have been COVID negative, but they didn't have their vaccine boosters, to get them to get that done, whether at the practice or at one of the available pharmacies. And so, that's been, I think, a useful tool. And it's also been a way to keep up with chronic condition patients who, for various reasons, were afraid to come in the office, or were, had transportation issues or other physical issues that limit their ambulation. And so it's always often been a good way to see some of the patients, how they're appearing in their environment, which also is a help for a clinician to understand. So again, it's been overall really helpful, also in the behavioral health realm, and helping to screen out patients who were having behavioral problems because of the pandemic or other issues of stress and all the other things going on in the world. So it's been a great tool. Again, we still would need patients to, as Peter was talking about before, they still need to have access to either coming in for a point of care test, going to a lab to do some of the tests, or getting a vaccine, and scheduling, for colonoscopy. And again, we've tried to make that as easy as we can for all of those things. And we do have a fast track method for colonoscopy screening. Yeah, so telehealth, I hope will stay around for a long time, and hopefully develop into some of the other methods of artificial intelligence and having some tools being able to actually examine patients to a greater degree remotely.
Anyone else?
Yeah, I was going to jump in and say, so we have seen since the peak of COVID, we have seen a lower volume of telehealth claims come in, with the exception of behavioral health, which continues to stay at higher levels. And I am a strong advocate and supporter of the telehealth for behavioral health services. I think it's a way to address access, you know, if there are access barriers, as well as making people comfortable, reducing stigma. So, you know, I just think that it's I would hate to see us go backwards in that respect.
Yes, it's important that we don't go backwards in that respect. And excuse me, living in a place like the Virgin Islands, and when you look at other rural communities, it becomes even more important, where they may not have the number of physicians needed, or physician may be there periodically, but it's really a critical tool that we need to urge continues to be used. So we do have some questions and comments from the audience. I have a question from Leslie Bivens, who says, why does some testing recommendations stop after certain ages, like 80s, people in the 80s? We're living longer. I'm getting close to that age. Is there a reason why some of our clinicians are not, and other individuals who are on our in our audience, not seeing the same kind of testing recommendations at older ages?
So as somebody who takes care of a lot of senior citizens, I'm happy to start that answer. We tend to look at benefit and risks of testing, and again, the issues we just talked about of false positives and false negatives and unnecessary testing. So what has been found, and I think many of us use the United States Preventive Services Task Force recommendations as one of our ways of looking at evidence-based testing. And also then our specialty societies for various aspects of medicine. Our state societies often look at guidelines around the evidence as well, and often stemming from the United States Preventive Services Task Force. So there's levels of recommendations that come out from that task force regularly, and sometimes new items are entered, like recently looking at HIV screening and hepatitis C screening for all adults at certain ages. And then, but it has been found certain tests like pap smears, it has not been recommended over 65, because again, looking at benefit, risks, costs to the patient, inconvenience and discomfort to the patient, at certain points, it seems like they're, the benefits don't outweigh the risks. And so that's why, and the evidence has not shown that you will detect certain levels of cancer for average patients in the population. So that's pretty much, I think, the strategy for why certain age groups are looked at, and it's always still up to a clinician to decide. You know, for somebody who is higher risk, then perhaps you still would do that colonoscopy at a later age, or that pap smear after 65. And so again, the conditions of insurance may sometimes limit us there, and Medicare coverage. And so there is often some administrative burden, I guess I would say, for that. And hopefully that's something that we can continue to work through with our colleagues in the insurance realm. So I hope that answers the question. Maybe if others could chime in.
I would just add that, you know, the research that's behind the risks and benefits, and I'm totally on board. I mentioned PSA testing before in certain age groups, right? Over 70 or over 80, the risk reward ratio or the value of actually diagnosing it is questionable. But I will say that our research is lagging behind, and typically you've got to do a study. It's got to be several years for a study before you come to conclusions, and then you implement a solution. And our aging population is getting healthier and healthier. And the research showing the value of doing testing in that aging population is lagging behind what might still be valuable to do. So I'm on the fence about relying on the data. And, you know, Valerie, maybe you can comment on how the insurance company decides what to reimburse for and what not to reimburse for. But there are clearly different segments of population with different health concerns that we need to treat and segment differently. And we're not sophisticated enough to do that yet, you know, to make a blanket statement, 80 is the cutoff date. But that's the world we have to live with. And that's a challenge. That's a challenge.
Yeah, I mean, I can't speak in detail. I just know, you know, we have medical policy committees, and we would be following, you know, the medical guidelines. I think that some of you have mentioned. I think we talk about Milliman. There, you know, we would be looking to that evidence and those clinical guidelines. I think is you know, and so I think that's a really interesting point in terms of if that's lagging. You know, that is what I would assume most of, you know, clinicians as well as insurers are following the science at the moment and those guidelines.
Yeah, and
Can I just say, you know,
Sure.
One thing about lab tests, a normal range includes 95% of the people. So there are 5% of the people that are above or below that normal range that are normal. And I think when we apply that to individuals, we're talking about individuals as opposed to population health here. I think we have to leave it in the doctor's discretion to decide, is this appropriate, even though they fall outside of the guidelines, which themselves might be dated. But I'll leave that. That's a whole other conversation.
But I agree with that. You know, the doctor may, for good reason, decide that a particular test might be necessary in a person where it's not recommended. But then comes that administrative burden of explaining why it's being done and so forth. But also the research, because with something like PSA, we really need to know what needs to be done if a PSA is high at a person who's 80 years old. And I don't know that we have enough information yet. So the research is also very important.
I was just going to add, could I add one more thing on that? Just that it is important to look at, and the seniors look at their functional status, and, you know, there are different people who age differently. And so, again, you know, you wouldn't, for somebody who's extremely active, an 85-year-old and has no other conditions, you might want to do more screening, such as a mammogram. But, you know, again, all taking into context, then that whole, would you really change your behavior for that patient if the test is positive, as you were just saying, for somebody who with a positive prostate exam test at age 80 or 90?
And this is not really a question. Susie Dyer says that they use Uber Health to help overcome some of the transportation barriers. Is that something that any of you have used, or have other suggestions for overcoming the transportation barrier, especially for rural populations, communities of color, poor communities? Transportation is a barrier. So can we speak to that for a moment?
Yeah, so again, that's where telehealth has been a huge help, as you referenced, for patients who cannot get to the practice, whether they're rural or urban. But we have utilized a service similar to what you're describing, called, in this area, is called Ride Health, but it's based on that platform of Uber model. That has been a big help as to supplement. There is also a state-based program for certain individuals with limited resources, not as easy to access as it could be for some patients, I think. So this helps to supplement that.
And from the testing point of view, if people are designated homebound, then we provide at-home testing. So, and there's testing can be just beyond, blood tests. I mean, EKGs and even chest x-rays and so on can be done in the home. So that's something people need to be aware of and make sure their patients are appropriately designated.
Yeah, the state Medicaid agency does provide with a transportation broker for non-emergency medical transportation for those other members, non-Medicaid members, or in the event that there's, that's not working, through our Neighbors in Health program. If they're engaged with our community health worker, we will arrange whether it's Lyft or Uber, bus passes, whatever it takes to have the member transported. I know also in our Braven, our Medicare population with Braven, we have a program called Papa Pals, where there is, that's also, these are college students that are providing companionship and addressing social gaps for some of our members going into the home. So I think more and more it's, meeting the member where they are. But yes, definitely making sure that transportation is provided, because I think as we're trying to address health disparities that became so apparent during COVID, access to primary care, I think, is probably the most important way that we can close some of those health disparities.
And we've run out of time for questions. I think I need to move to Tyler for our wrap up. Am I correct?
Yes. Can you hear me okay?
Yes, we can hear you fine.
Okay, great. Well, thank you so much, Dr. Christensen, and our speakers, and to all of our Quality Institute members who joined us for the program today as well. If you are not a Quality Institute member, please reach out to me and I'd love to tell you more about it. Also want to give a quick plug for one of our upcoming events. We do have another event on February 1st from 7:30 to 8:30. It's virtual, and we're going to be talking to all of our quality teams throughout New Jersey and all of our hospitals about quality improvement and the work that they're doing on the Leapfrog Hospital Survey, as well as how to make patient safety and quality a top priority for their organization. So please use the shortened link there to register, and we will also be sending out a recording of this event after the program ends, a copy of our quality briefing, which we put together in companion with the event, and then also some of the resources and materials that were discussed today. So that was all I had. Thank you all so much for joining us, and hopefully we will see you for the next event. Thanks all.
Thank you. Thank you to our panelists, and CQC has been really pleased to be able to be a part of this presentation.
Yes, thank you to Consumers for Quality Care for supporting us for this event.
Thank you all. I saw, Tyler, there's a couple of questions in the chat. Is there a way we can answer them offline?
Yes, absolutely. I'll share those with you, and we'll get you the email addresses to answer those questions.
Thank you.
Thanks, everybody.
Thank you.
Bye-bye.